the first one is the burning question. Will we ever really cure diabetes for good? Who would like to answer? Please, the speakers, perhaps, who would like to answer, maybe raise your hand. Now we cannot see. How do I go back to the speaker view because I cannot see the speakers? Stop sharing. Where?
Magda, do you want me to take it?
Yes, Chantal, get started while I get rid of this window.
Okay.
Yeah.
So I think Emma's work is very important to answer this question. But if we go to type 1 diabetes, we're understanding it better and better. Will we ever cure it? I am sure we will prevent and cure this disease. And I don't know if it will be during my professional career, but I am convinced that is a curable disease. Will we cure type 2 diabetes? There, we know it is such a heterogeneous group of diseases coming together with insulin resistance, with beta cell failure, with all kinds of things going wrong. When Ken said, I'm being referred to my general practitioner, that is a thing that is so strange that we send the people with the most complex disease to the practitioners that need to be more general. Because treating type 2 diabetes is as difficult as treating type 1 or any other form of diabetes. So will we cure type 2 diabetes? I am not sure. I think we will treat it very differently, but whether we will be able to do something and then not need treatment anymore in type 2, I'm not convinced.
So maybe let's hear from those who know a lot about type 2, or really there's not just one, right? So maybe we can cure some of those, or I don't know. Maria, please.
Maybe I can comment. I completely agree with Chantal's view that it's a very heterogeneous disease. So to cure diabetes is a very broad question. I'm sure that we are going to be able to prevent diabetes in certain groups. And I'm still quite optimistic that once we are understanding a bit better the etiology behind each of the different subgroups, that we will be able to come closer to a cure. I think it's related to the other question that was on the panel and got quite a lot of scores too. It's a complex disease that engages several organs. So I think it's really good that the field is moving from a very pancreatic beta cell centric approach and to seeing the whole patient, all the organs that are involved and how they interact with each other. So maybe we would not cure it completely in all groups, but I'm optimistic that we are already now able to provide more options to have a better quality of life and to delay the complications associated with diabetes.
Yeah, so if any others would like to comment, I invite you, but also you can fold in the answers to the second most popular question from the poll, which was, what is the biggest breakthrough since we've gotten the insulin? Because it's related, right? Breakthrough meaning, you know, like towards the cure or towards better management, prevention, diagnosis.
Again, I'll kick off. I mean, when we talk about the discovery of insulin, it's not a one feat, it's a whole journey. I mean, the injection of insulin was nothing if they were not able to purify it further in the years after and make analogs and make better insulins. And it would have been nothing if they were not able to measure glucose levels in the blood and then miniaturize them and then come to the sensors. And so it's a whole sequence of evolutions. And what is nice, and Edouard is very quiet, but he will agree with me that the last 30 years being a clinician in the field of diabetes was amazing, because we have seen so many changes. And honestly, I think pediatricians, GPs, and endocrinologists invented the word holistic approach. We were organ agnostic from the beginning. We did much more than just control glucose. We looked at the whole person living with the disease. So to me, it's a journey with many, many highlights.
Any other comments? Edward, don't think that you cannot say anything until conclusions.
Yeah, I was thinking about whether I should also provide some concluding remarks to this the discussion. But I fully agree with.
Can be repeated.
So no, I was thinking about this question about what a major breakthrough, and I fully agree with Chantal. This is something that evolves, and probably not even. I mean, clearly, insulin, the discovery of a molecule that really saves lives. I mean, because that's so important. I was glad to see that picture that you showed, Chantal, initially, because diabetes was really a death sentence at that time. It's still the same, and it's very important that even in the current world, in some of the difficult situations, in places in the world where there have been some catastrophes or some wars, people with type 1 diabetes that are deprived of insulin die of decay, diabetic ketoacidosis right now, even now. So it's still that. But that's an important thing. But there have been so many things that have changed in the last 30 years. I think that a turning point also was Chantal or anyone else, but them proving that in the intensification of the glucose control really had a strong impact on the diabetes, on the complications of diabetes. Was not a breakthrough, but it was so important also to prove that we were able to prevent and to reduce the complications. And now that has evolved again, and the focus is not only on blood glucose, but is in this more holistic approach, the cardiovascular approach. So it's that continuum that probably being able to prove at that point that we were really able to reduce the burden of complications was very, very important at that point. It was quite both in type 1 and almost immediately in patients with type 2 diabetes. It's something that was proven. That was also very, very important, I think, and that has evolved in the more recent years now, because now we are able to prevent cardiovascular disease also, and I think that this is another very important change in the way we manage diabetes and we approach it.
There's a very close link there, isn't there? So Maria, I see your hand raised, but what about Emma? She's so quiet. I cut her off, so she's mad at me. Emma, please, what do you think?
I don't know. I feel like what the others have said, that it's not one thing. It's hard to pinpoint. It's a development. It's many small contributions leading to something important. And I think it's difficult to see what will be the important things that will lead to important changes. And I think for type 2 diabetes, I think the development now with people more looking into the heterogeneity and understanding that we cannot think of everyone as having the same disease. I mean, I think it has the potential to really bring the field forward. I don't think that my work as such is a breakthrough, but I think that this insight and in the field and the interest in looking at precision medicine will be very important for type 2 diabetes. And also for other diseases, because I think there are many diagnoses where individuals with quite different symptoms and profiles are grouped together and treated the same, and often by general practitioners who are not specialized enough to understand this heterogeneity.
Yeah, I think this has been kind of a trend at IMI. We have seen this in almost every disease area. They all realized it's not one disease. Asthma is not one disease. Diabetes is not one disease. You name it. Diabetes is my portfolio, so that's what I think about. But it's like this almost anywhere you look. So we just have to keep digging deeper and keep uniting to divide, divide to be more precise, to approach the patient, but be united in our approach and exchange like our methodologies, right? Like all the omics data federation, being able to handle samples, all these things that were mentioned. I don't want to monopolize Maria, and I want to also hear from Virla and Ken, but I have a special question for them.
Yeah, no, I just want to reiterate that this is like a long process, and there are many breakthroughs, and it would be unfair to highlight one over another because there have been dramatic changes especially in understanding the risk factors that lead to disease and to complications, and acknowledging them as important determinants, and along with that, in increasing the number of drugs that are there available to manage those risk factors. I think and just the introduction of statins not that long ago to reduce cholesterol levels in plasma are also contributors of complications, or blood pressure lowering drugs or anticoagulants. There's a lot more that we can today offer. Again, we need to solve this issue that one drug doesn't fit all, and that we need to understand who is going to benefit more, but we have a lot more to offer and to play with. I mean, it's not like long ago that we had almost nothing apart from insulin. It was just very frustrating because you were just monitoring things, but we couldn't offer much of a help. So I think we need to be proud. And again, hats off for our industry partners that did a lot of heavy lifting in developing those drugs, and all that know-how that is accumulated that we can use now.
Yes. So I'm going to skip the question about the psychological support because Virla and Ken have answered it, and also did others from the scientific session. The glucose monitoring standards, we can touch on that, or we can put it on the website. I think it's all evolving still. And this is something that the new partnership Innovative Health Initiative can take on board, because all the stakeholders will be at the table. But anyways, Virla, a question for you from the audience. How does marathon training work if everyday life is so hard to plan? And you do not just do that, by the way, you're like doing so many different things.
That is a good question. It's doable, but it's hard. You have to be on your sugars all the time, and I'm not talking about the race itself, but it already starts the evening before that you handle things differently. Whenever you have a training or the race, I have my way of reducing my insulin, detaching my pump, taking a little bit of carbs. You're playing with it, kind of, on the way to the start line. So all the time you just need to be somewhere and hoping that it works to be able to do the race. But during the race, you're really checking your sugars all the time. You're detaching the pump, putting the pump back on, taking a little bit of insulin. If you're going down again, you have to eat something, but I don't stop. I just do that while running. So it's challenging, and actually you lose a lot of fun that way, because sometimes you just forget to look around because you're so focused on the sugars. But it's doable, and some races are, and during some races I had really good results, and during others it was a total disaster, like the London Marathon. Someone passed and pulled out by accident, of course, my sensor, my CGM. So there I was after 10 kilometers without my Dexcom, which was not so good. So I had to stick my fingers. I went too high, I went low, and I don't remember anything from the surroundings. So yeah, it's a choice you make. Sometimes it goes really well.
Wow, you shouldn't have to make these choices, right?
It would be, sometimes I would tell people it would be nice to run one marathon without diabetes. I think it's a completely different experience, to be honest.
Yeah, without your wife or husband, right, Ken? So let's switch to Ken. We have a question for you. There's someone who is, let's say, in the same geographical area, but I think it's a problem not just in UK. She also has, I don't know if it's a she or a he, because it's a kind of a name that I'm not familiar with. But this person also has type 2 diabetes, this person cannot get prescribed tests or insulin for that matter, or prescribed. Sure, she can probably get it to pay, but the insurance won't pay for that. So how do you do that, especially in UK or in other countries where this is not the standard of care?
In the UK, we get our things for free from the NHS, except for people with type 2 that you don't get the flash thing, CGMs. I have to pay for that. I self-fund it. If you can't take insulin, I didn't quite get, did you take it or couldn't you take it? Because you broke up a bit, or the person, Magda.
So definitely was about test. I'm trying to find this question again.
Sorry.
But no, I can't see because I'm becoming blind. Lancets and test strips. My doctor was very helpful and he prescribed these two for me last year, and as a result I was able to control my glucose level much better, maybe just by, you know, diet or whatever. Is there any way that type 2 diabetes can get these prescribed in the UK, but anywhere really?
Yeah, no, if you're type 2,
this person is even on insulin then.
No, if you are, it doesn't matter whether you're on insulin. If you're on insulin type 2, you are supposed to get at least the test strips and monitor. If you are not on insulin, then according to NICE, you know, the National Institute of Clinical Excellence, they say that type 2 do not need to have any form of testing. So to me, that is a lot of, and I'm not going to be polite, bollocks. Sorry, Chantal, my English is better than yours. We need, if you're, it doesn't matter what type of diabetes, whether you're on oral or whatever, you need to understand what causes spikes. You need to understand how your diabetes is working. I mean, I've just got this flash for the last 4 months, and I've understood for the first time in 22 years what my diabetes is actually doing and how my body is reacting to the insulin. I would never have had that if I hadn't paid for it, put it that way. Does that answer the question?
Yeah, I think, yeah, of course you did, but you know, from the question, it seems this person is not even on insulin. It's just about managing the sugar levels. And this person is not even asking for like a continuous glucose monitoring thing, just test strips. That's like the low tech, as low as you can go, and probably the cheapest. But besides the point, so I have another question, which is kind of to all of you. But the question says, would you consider the work done with patients as part of the citizen science movement approach? I guess this is the new buzzword. So would you consider that the work with specifically patients, but you know, we don't like to call you patients, you're people who happen to have this damn disease, and you have to live with it. You're not like in a hospital. You're people who live with diabetes. So to me, the quick answer is yes, but I don't know what you think. Citizen science movement / approach. What do you think? Maria, please.
Yeah, I think it's a really interesting concept and it's something that could be exploited. We did that with the COVID symptom study that we launched during this past year, and that has been absolutely amazing. We have 4.6 participants enrolled in the study, as I mentioned before, and that has provided a lot of data, a lot of longitudinal
participants. Maria, 4.6 participants.
4.6 million participants. Yeah, and 370 million points of data that have been introduced to that database. It's one of the largest epidemiological studies ever conducted. The richness of the data is incredible, and with it there are biases, of course, because you're self-reporting. There are lots of limitations, but it is very, very powerful, and it's live. It gives you information that is very relevant to what is going on at the immediate moment. So for some questions, it could be very, very relevant. I'm very positive, and I'm happy that the pandemic has pushed us a bit further to test that concept and to maybe evaluate whether it can be used for other questions within diabetes.
All I can say is, wow. You made me speechless.
If I may add, I mean, to me, there's no other way. It is the people living with specific diseases who will decide also what is happening with their tax money. And so having people with diseases weighing in on where the research portfolio should go, how research is conducted. I don't say they need to decide on the dose of a drug, but they need to have a voice in how the whole thing will go. And you know, I'm extremely worried about where research will go for a disease like diabetes, because diabetes is not sexy. It's in type 1 diabetes, it's a disease where I get a lot of remarks. Oh, well, you have new insulins now, you have technology now, what's the big deal? And then in type 2 diabetes, and sorry, Ken, I'm sure you heard it, you know, let them diet and everything will be solved. So it's not a sexy group of diseases that end on the, you know, on the other hand, it demands very specific approaches. It's not the same as rheumatoid arthritis. It's not the same as cancer. It's not the same as all these other diseases. And I understand that we need to be disease and organ agnostic and what have you, but do not drown diabetes in the whole sea of other diseases, because it needs specific approaches. And there, I believe it is the people living with diabetes who will save us, because they, by telling their stories like Ken and Veerle just did, will demonstrate that diabetes deserves attention. I have a patient with a breast cancer and type 1 diabetes. And she told me, Dr. Mathieu, my breast cancer is horrible. But I can forget I have breast cancer when it is Christmas. I can never forget I have diabetes. And so we need to find a cure for type 1 and better treatments for type 2. And research is the only thing that can help us. So please keep focusing also on diabetes and the other non-communicable diseases.
Exactly. They're all connected and somehow related. But what I can say to you, Chantal, and my very funny approach, but it's not funny. You know, sure, diabetes is not sexy, but some other things are, like cancer, like, I don't know, COVID right now, other things, neuro or cardio. Why don't we just link it with the sexy things? Get on the wagon and say, actually, you know what? If you have diabetes and that, or if you have diabetes, then you might be more likely to get that, and so on and so on. Just an idea. So, what else should we talk about? Anybody else wants to comment on this? Actually, sorry, I didn't want to cut anybody off. There's your chance.
I think when it comes to citizen science, I think it's a very interesting concept, also connecting to what Veerle commented before. That I mean, she's been involved in one consortium and has had those channels to engage, but that's not the case for every diabetes patients. And before getting engaged in a consortium where you could get your voice heard, it's sometimes very difficult for patients to tell their stories in the right forum and not to take into account. So I find it very interesting, the citizen science story, because that's an opportunity, and also an opportunity to be a lot more interactive when we're designing our studies. Obviously, we have integrated patients in the design of our protocols, but those are a few patients that are very outspoken. With citizen science, you get immediate feedback. When you launch questions, you get feedback, but that question doesn't make sense. You should ask it this way, and you should take this into account. So you are continuously kind of redesigning or reshaping the way you are interacting with the patients to collect information that is relevant and information that could change throughout the years because we are evolving and we're developing new treatments. So it's a very dynamic process. And I think that's also one of the major advantages of these interactive platforms that give us the opportunity for that.
Yeah, I'm going to take this opportunity to ask one last question on behalf of someone from the audience. And this was actually my question when I found out about this reclassification of diabetes. You know, I've followed this since it became a thing. But this person is asking, you know, first of all, this should be much more publicized. I mean, scientists probably know, especially scientists in the field, but scientists who are not in the same field, the doctors, even patients, people who live with the disease, they don't know. They don't know. They could already probably manage their disease better on their own. But what about the doctors? What about clinicians, those GPs who don't know what to do with this very complex disease? How soon can we use this in the clinic? When, you know, when? Do you have any estimation? I guess Emma would be the question for you, or maybe together with Emma and Maria.
You want to answer, Emma?
Yeah. So I think it's one thing is just that's important is just the general understanding and bringing the attention of GPs to the fact that there are these differences. Then as for implementing this in clinical care, this needs to be done very carefully. So we are doing this. There are some studies ongoing looking at response to treatment in the different groups, but we're also looking at how we classify it, because this has been done by computer algorithms, which is great because they have no preconceived notions or bias, but they also have no common sense. So it's very important to check that what comes out of this is safe and correct and doesn't bring anyone astray. So we are starting to try this now in the UNDIS cohort. So all the technical stuff is set up and ready to go, and we will try it a little bit, but without any specific recommendations, because we cannot do anything like that until we have proper evidence that we are doing good.